The subject of this panel is health insurance exchanges, or more recently, the health insurance marketplace. A hot topic, as you know. If you're looking for ACOs, they're across the street. Discussion of that at the Fox. With this session, we're right before you in the reception, so we're very cognizant of that fact, and we'll try to be succinct and brief and to the point. Our format is one of which we'll open with a question for each of the experienced panelists we have here. And then we'll have, each one of them will answer that question, which is a broad open-ended question, and then we'll have questions for each, I guess 2 rounds, and then we'll open it up. We have a format around 4:30 or so. We'll have a question and answer from you, which may be very lively. And I'm not sure over here if it posts online with the hashtags and everything, but maybe we'll get other questions that way. And then Pat Williams here, she's going to summarize, I think, about 4:50 for us as our plan. Any question in the audience before we get started? Okay, I want to introduce our panelists briefly. There's some description of their background. They're all very experienced in the field of health insurance and the healthcare system. First to my left and your right is Bill Custer, who's an associate professor at the Robinson College of Business at Georgia State in our Health Administration program and Risk Management Insurance. Previously, he was Director of Research at Employee Benefits Research Institute in Washington. And I assume you've seen him almost daily being quoted in the Atlanta Journal, TV, and other places these days, particularly over the last month and a half, as some of these other gentlemen have too. To his right, from your standpoint, is Tom Davis. He's former Senior Vice President of Coventry Healthcare, and he grew their program considerably, and previously held positions at United Healthcare, Metro Health, and Prudential Healthcare. And welcome to you, Tom, to sit on this panel as well. To his right, from your standpoint, is Dan Styf. He's Senior VP of the new Piedmont-WellsTar health plan, and he's currently working on and has now launched a new Medicare program, a commercial health plan for the Piedmont and WellsTar health systems. Previously, he was with Kaiser, Henry Ford System, and the Alliance Community Health Plans in Washington, D.C. And over here on the far right, for your standpoint, is Mike Dendy. He's CEO and President of Advanced Medical Pricing Solutions. He was former CEO of TPA firms. He's worked with large and middle-sized employers, TPA, self-insurance plans, HMOs, whole focus of areas, and particularly brings the employee perspective to our attention. He's also been quoted widely, and most recently, I think, perhaps in the Wall Street Journal, New York Times, or whoever I'm leaving out here. So we look forward to your comments. Finally, I guess I should say myself, I chair the Health Administration program at the Robinson College of Business, have a wide experience in academic medical centers, health systems, CDC, and elsewhere. And in this arena, I was chairman of the board of the first Prominent Health Plan, which was the largest integrated health system, certainly in this area. It's #1 ranked in the United States in year 2000. So I have a lot of experience with that, which we can share. So the first question I have of everyone, and perhaps in this order here, starting with Bill, would each of you briefly describe how your expectations for the operation of health insurance exchanges have changed, particularly over the last month and a half?
Well, I would say they haven't changed that much. In spite of the really bad, no good, horrible implementation decisions that have been made over the last year and the IT problems, you have to remember that the that this proposal that became the Affordable Care Act has been in the works for 30 years. It was created at a time when the mental picture of a health insurance exchange was a shopping mall. And people would go and look at booths and make choices based on that. The underlying changes in the health insurance market have already occurred and are occurring. One of the problems we're having with the implementation is that all of those changes are happening in a step instead of simultaneously. But all of these changes were anticipated, and I'm presuming here that the IT issues can be resolved in some type of timely manner, and the law will be enacted and implemented as written.
So I would agree that things are rolling out in many ways as you would expect. There are states where this is going to work well, despite some process issues. So if you were in New York State, for example, and you had guaranteed issue without a mandate and a whole bunch of regulation which caused a very, very high-priced individual market, all of a sudden offerings are looking great. As a consumer, you'll save money with or without the subsidy. There's some access issues at the moment, but for New York State, this is great legislation, and New Yorkers will be happy. For a state like Kentucky, which has gone all the way, has Medicaid expansion, has worked very hard to educate people in the marketplace, I wouldn't be surprised if it has the highest enrollment of any state in Canada. And in a state like Georgia, which has implemented this partially, has educated partially, and had a very different individual insurance market where you had a lot of new entrants, including the company I worked for, who were able to offer individual insurance at a very low price. This is going to be a tough sell. And so I think all of that is what I would have expected months ago, and seems to be playing out at the moment.
Yeah, I think in some ways the insurance offerings that are available this year, in my mind, when I look on the exchange, and so now you can actually get to these insurance offerings without having to log in and create a password. So when you go look at them now, I think there's actually more innovation in network design than I would have even expected in the first year. There are products offered on this exchange that have 2 primary care providers in Cobb County and 1 in Gwinnett County. And that's, when I moved here 6 years ago, everyone told me that in this town, everyone has broad networks everywhere and you can't sell in their own network. And now when you look at the options that are there, they're very, very different than what's happened before. So I'd argue there's a lot of innovation that's actually happening, and it'll be very interesting to see how that plays out.
Mike?
From the exchange perspective, I think anyone who thought that the additional competition that the exchanges would create would reduce costs, that's an absolute pipe dream. Nothing is going to reduce costs until we shift the paradigm in how people buy. The individual consumer has to be tied into the price somehow. They have to be price sensitive. And then the providers, the doctors, the hospitals primarily, have to be totally transparent. And we are eons away from that, from everything that I can see. So if we think that just having more competition is going to drive down costs, that's not going to happen. It's going to be more of the same old, same old. The people who are going to jump in and purchase from the exchanges, especially from the individual perspective, are only going to do so because they're subsidized. And over-subsidization is bad at any point. It's bad in healthcare, it's bad in education. So I think we've got a long way to go, but certainly at least getting started, there are going to be some different points of entry. And there are some positive green shoots that we can talk about as we get into this session.
If I can add my comments, just thinking about an example yesterday, my son's fiance is in London, who's moving back to the U.S. Yesterday was the last day to declare for her open period, and so I was sent information on 3 health plans. And for those of you interested in doctoral programs, I think you need 3 PhDs sometimes to figure out these plans. So I encourage us to all try to think of simpler ways to do this. Let me ask again, if you can't hear any of the speakers, raise your hand and we'll try to speak more distinctly for you. Next question we'll have for Bill. What are the total number of people who are estimated to be in the health exchanges, and which state seems to have more of the folks in the health exchanges, and where does Georgia stand in all of this?
Well, I think Tom described it right in terms of where Georgia stands. We estimated 3 years ago that there would be 600,000 people in the exchange when we were fully up and operational in 2016. So the number we hear most often now is around 400,000 who would be in the exchange. You saw the White House estimated, or CMS estimated, there'd be about 600,000 Georgians who would be eligible for a subsidy within the exchange. Whether those people, how fast those people move and take advantage of that is an open question. The problem with the website, even though I kind of skipped over it in my opening comment, is huge in terms of attracting those folks who are eligible for the subsidy and who are younger and healthy. This is my shopping mall model is an old reference. I'm constantly talking about Marcus Welby, MD, and none of my students know who the heck I'm talking about. And shopping malls are moving in that direction. To reach that population, you have to market electronically. And that's going to be an issue in the short run until the website is fixed. But the dollars, in terms of the mandate, get fairly large for those folks fairly quick. And the rewards from entering the exchange go up pretty quick. And one of the things, we probably touch on this later, but one of the consequences of Georgia not expanding Medicaid is that premiums within the exchange are about 10% higher than they would be if we had expanded Medicaid. And I'm betting that we will, as a state, expand Medicaid in the next couple of years. And that rollout is going to change the terms of who's in the exchange and what they're facing in terms of prices.
Okay, anybody that has anything else to offer here, feel free to jump in here. Tom, how do you see the individual health insurance market evolving over the next, let's say, 3 years or so?
So one thing which, the people who thought of a big bang, so if you like your physics, the big bang, you have this huge consolidation down to one point, and you go out, not happening here, right? So a bunch of things are moving 2014 to 2015. And so some of those things are problems with the mechanics of the website. Part of those things are every carrier with individual health insurance has gone out to do early renewals. And so what they've done is say, wait till December 31st in the afternoon to renew your policy. And then you'll be able to take your old policy, which you paid $150 for per month, and you'll be able to keep that for most of the next year. And all this Obamacare stuff you don't have to worry about. And that's happened for individuals, it's happened for small groups, and it's happened for some large groups as well. But it basically takes people out of that pool, which makes the pool look worse in many ways. And so one of the interesting questions here is the pool will look worse because people didn't enter it. The pool will look worse because there is this, what you'd expect in people who didn't have health insurance suddenly getting health insurance the first year has a bunch of unmet demand and the crest that comes with that. And probably just some things associated with size. All the rates for 2050 will have to be filed well in advance of any experience. So what will happen in this dynamic is if insurers want to keep their prices as low as possible, they're going to have to make some adjustments to their network, they're going to have to make adjustments to their pharmacy, they're going to have to make maybe some organizational adjustments, maybe new pieces of paper to go out to change their risk pool and how that's accounted for in order to get to 2016 in any kind of reasonable health. So I don't see, again, 2014, muddle around, 2015, haven't done much, 2016 is when I think you'll see the change.
I can see as we go through here, you're probably writing down some questions to ask here. I can think of about 4, but I'll hold those. Dan, could you let us know how the health insurance exchanges might have influence and might in the future influence the competitiveness of the marketplace?
Absolutely. Well, I think my organization is one of those that that the value proposition for a delivery system entering the health insurance marketplace, essentially going straight to individuals in the community and saying, hey, we can provide your coverage, is something that's very hard to do when only a very small portion of the marketplace can choose you that way. Because today, as you all know, many health insurance companies are built around the value proposition of approaching a benefits manager or working with a broker in the community, approaching a benefits manager and saying, we're going to have enough doctors in a network so that all of your employees will be able to get the care and coverage they need for the next year. And that's one way to design a health insurance and coverage system in the country. Another way is allowing families to go and make that decision on their own, independent of whatever their CFO or their health or human resources person in their organization might choose. So the idea that more and more people will be purchasing coverage either through some type of individual exchange or, as importantly, some of the larger private exchanges that are being set up by the big consulting houses, that's a huge change. And when big employers in this community, you look at places like Walgreens and others that are moving their employees, Sears, to these type of environments where they give their employees some money and say, here, you have $500 a month, now you go choose among the options. When a family's choosing, they're going to look at a delivery system, this is at least our belief, a delivery system like WellsTar or a delivery system like Piedmont, and say, that's where I get my care anyway. Why go through these other channels to get my care when I could go straight there? And so I think that actually creates a sea change in the way that, that the market, who is playing in the market, and the value that the different people in the marketplace may provide. So the value Blue Cross has traditionally provided may be different in a new world, and maybe we're competing, we being Piedmont-WellsTar, directly with a Blue Cross more so than what we have been in the past.
Sure. Okay, that's a lead into our next question of Mike Dendy here. Given this tightening that we're seeing in the provider networks and the plans offered, both through the health insurance exchange and perhaps in our employer insurance, what do you think will be the impact of the healthcare pricing and costs in the future, Mike?
There's a really good chance that there'll be a positive impact with healthcare pricing and costs, and Dan's exactly right. If we want to cut healthcare costs by 50%, we can do it. Eliminate the PPOs tomorrow and give everybody the money, the check that we talked about, and you'd eliminate healthcare costs you would cut healthcare costs by 50%. The PPOs mask what you're actually paying for. Nobody knows what they're paying for because there's this opacity. And I mentioned that I saw some green shoots out there already in this way. And there are two of them I'll bring up. The first one is the California exchange. And I guess it's probably the most mature exchange. And I believe there's 6 payers in that specific exchange. The first thing they announced together that I saw was the elimination of Cedars-Sinai Hospital and UCLA Medical Center from their network because they were too expensive. Now, we had a president that say, you can keep your same doctor, you can keep your same hospital. Well, that's not the right thing to say. If you want healthcare costs to be more affordable, you have to eliminate the really high cost providers. The average county-owned hospital in America has an average bill charge rate between 400 and 600% of Medicare. The private hospitals, the ones that are publicly owned, the HCAs, the HMAs, the tenants, their charge masters start at 700% of Medicare and go to 1,000% of Medicare. And then all the PPOs discount off of those numbers. So there's no possible way to get a good deal. A 50% discount on 1,000% of Medicare is a lousy deal, and you're never going to get healthcare cost reductions there. So for Dan's type groups, he has 2 organizations that are not overly greedy in the way they bill, and they're going to have to change the way they're looking at it. So you've got the California exchange, and the fact that they excluded the 2 really high cost providers is number one. The second one is CalPERS. And if you look at what CalPERS did in California, this is probably the best green shoot that I've seen. They went to reference-based pricing, reference-based reimbursement on several dozen medical services. What that means is they said, if Bill wants to go have a knee replacement, we will give you 20 grand. So you can go to UCLA Medical Center where they charge 100, you pay the other 80. Or you can shop around with our help and we'll put up the 20, which you can probably get done for 20. And they, of course, they've researched that. That's available, and that brings medical tourism into play in any community. And you can get that knee replacement done at Henry Ford Hospital, I bet, right now for 20 grand, because they need the business. UCLA Medical Center, Stanford, Sutter out in California would probably balk at that until they start losing business. And it's already been proven. As soon as CalPERS announced that program, hospitals started reducing their rates because they didn't want to lose that business. So until we eliminate these PPOs that create this opacity between the payer and the provider, you're not going to see rates drop. As soon as those go away or they become very limited, you have direct contracts with providers, all of a sudden you'll see rates drop precipitously. But that's got to happen first. And the final point is the positive thing about the ACA that I haven't read anything about yet, and it's just now starting to bubble up, is there was a moral imperative placed on employers before the ACA was passed. Now the employers out there are looking and saying, you know, before, if I had 100 employees in my company, I had to gear my health care plan for my sickest individual because they couldn't get health care anyplace else. That's been eliminated. You can go get health care someplace else. So now I, as an employer, can manage my health care plan the way I would anything else in my business. I can manage it properly. I can manage it intelligently. That's going to change the way employers who are a big purchaser of health care buy health care, and how their employees then have to buy health care. So that moral imperative being reduced, if not eliminated, is going to change the cost of health care more than anything else that we can possibly do.
Okay, Mike, did you explain the CalPERS, what that is, that organization?
Well, I mean, CalPERS is the who makes up CalPERS, Bill? It's the public employees of California, and they're very powerful. You remember they got in trouble a few years ago because they were doing all those crazy hedge fund things. But they're a very powerful organization, and they're the biggest organization in California, especially from the purchasing cooperative. And they just told everyone that they had covered. They're like a big employer. They told everyone they had covered, here's how we're going to buy health care from now on. If you want to buy with us, that's fine. If you decide to go someplace willy-nilly without asking the price, without doing any research, anything beyond what we lay out as a budget, you're going to pay for yourself. So they're actually creating consumers. They're creating consumerism with the employees that they represent as an employer.
The reason I was bringing this up was because lead into our next question of how the public aspects can change the health insurance marketplace. And as Bill mentioned earlier about Medicaid expansion, so the question would be here, what are your thoughts, Bill, about what options do we have on Medicaid expansion in Georgia? Can we do like one middle U.S. state has done recently with their Medicaid expansion?
Well, I think you're referring to Arkansas, and Pennsylvania is trying to explore this too. Well, Arkansas is using a premium support program where the newly expanded, the folks who are eligible for the newly expanded Medicaid program are actually given money to enroll in the exchange in Arkansas. So they're buying private coverage with public dollars. That has the attractiveness of not expanding that public program. It's attractive to providers, of course, because private reimbursement is going to be higher. It's not as attractive to the insurance pool because you're bringing the Medicaid population into that pool. And so the 10% increase in private premiums I described by not expanding Medicaid is essentially brought back into the pool when they do expand Medicaid. Now, I should tell you, the expansion population, Medicaid right now as it exists in Georgia is you are eligible for Medicaid only if you're low income and something else. Income itself is not a criteria. But the law did, the expanded population, is it changes that to where anybody under 133% of poverty, actually 138 with a 5% disregard, is now eligible for Medicaid. Now what that means is that insurance group is pretty attractive. If you can enroll them, most of those people are not in poor health. Of course, we can think of the exceptions, and a lot of people are worried about homeless people with substance abuse and mental behavioral health problems and those high-cost folks. But that's just like any other insurance pool. That's a small portion of that pool. The problem is, if you're going to enroll them in that way, you've got to do outreach. You've got to get them. You've got to enroll a lot of really healthy people, or the private insured market dynamics don't work. But that means you've also increased the cost to the state, because you've got people who are now on your rolls who wouldn't be there, who would just say, I'm healthy and I don't care I'm eligible, I'm not going to the hospital, I'll never see you. So there's lots of issues with what Arkansas is trying to do. The philosophy was we want to expand the private market. The insurance problem is that how are you going to expand it? Who's going to pay for it? Now, a lot of people have run the numbers for Georgia on what it would cost the state to expand the Medicaid in a traditional way. And it's pretty convincing that in terms of the state taxpayers, the state taxpayers would save money if you expanded Medicaid. That is, more money would come to the state than new expenditures would happen. So that's why I said I think those numbers are pretty convincing. And again, they don't come from one source, they come from a variety of sources. Eventually those numbers will work their way through the legislature, and I think we will expand Medicaid. But I think when you take a good look at Arkansas and what Pennsylvania's trying to do, that probably would not work in Georgia.
Of course, here we're talking this afternoon from a non-political basis, economic basis. As you know, earlier today we had a different view from Georgia and whether we should do that. We're also not addressing the specifics of the IT problems per se, although this is certainly an HIT leadership center. Tom, could you talked a little bit about this earlier, could you make some prognostication here of whether you think the health insurance exchanges will grow, the number of insurers on the health insurance will grow in the future, perhaps if we could look past all these IT problems?
So here are the things which would cause a health insurer to want to enter the business. One, somebody else was doing well. So if you think that people will do well in this first year and will start a clamor of new entrants, then you would follow that all out. It's hard to believe that that would occur. So then you know enough to jump in 2050. What I think you may see is in 2016, you will see those provider-sponsored organizations who probably participate in shared savings, Medicare plans, or had other designs of moving to a more, and by the way, have bought a bunch of practices and therefore need to protect their new borders. They may want to participate, and they want to participate in that in 2016. So that may add a whole bunch of micro competition in different markets. And then we have one Medicaid plan which is participating in the exchanges. You would think that depending on what happens with expansion, some of the other Medicaid plans may also want to participate in some way, respecting that they have contracts that may or may not allow them to do that with providers.
Okay, and Dan, a follow-up of that, kind of a corollary question. How do you see the health insurance exchanges affecting the employer-based health insurance? Will we have more or less of that in the future?
Yeah, and so I'm going to answer this question. I want to follow up on something Mike said that I really liked. So I think you're already seeing that employers are saying to employees, if your dependents have coverage options elsewhere, we're not going to cover them at all. And I could make a list, and I would spend here for the next 20 minutes making a list of employers who are making that decision. I think that decision's a lot easier to make when anyone can actually go technically buy coverage in the market. That doesn't mean the coverage is affordable, but it's a lot more affordable than it was for anyone with a pre-existing condition in the past. So everyone can go buy coverage in the individual market, and so I think you're definitely seeing a change where employers are focusing more on their employees. I think that's moving you more and more towards this sort of direct contribution, defined contribution, type of model. And to the point Mike made, I think if you want to strike fear in a hospital system C-suite, say reference-based pricing, I think you're exactly right about that. I think the other point that's really important related to this is if you think about the investments that hospital systems have been making. Let's go back and look at the last 10 years. The investments hospital systems have been making first were in our cardiovascular suites, right? Everyone wanted to have the most cardiovascular suites because that's where the return was going to be, because that's where they had margin on their DRG. Now, if you look at the investments that hospital systems have been making, it's to Tom's point, they've been buying practices. And why does one buy practices? To define some territory, to make sure you have referrals. But the other thing that happens, I mean, the stories in this town are very clear, that as soon as you buy a practice and make it part of a larger network, the rates at which that practice can bill will go up significantly, and so you're creating, quote, value. By doing that, value for whom is the question. But I think in moving forward, to your point, the value that a health system has in investing in medical record technology or technology that allows physicians to actually work together to take care of the patients who need it, that's where we want hospital systems and other systems to make investment, I believe, because the return on that investment comes when care is actually better for the people who cost the most. And so their investment returns are aligned actually with our interests, I think our community's interests, which are lower healthcare premiums. So that's a huge change that's happening in the hospital industry, and it's one I think I'm very excited about. I never was too excited about building cabbage suites and places like that in hospitals, but I think this one really matters.
It really does matter, and you mentioned the fear on the doctors and the hospitals, and also right after this question of Mike, which is, we'll have the Q&A here, but what about your projections and how we'll see the practice of medicine and the hospital arena change?
Well, with hospitals, if you break down healthcare spending into a pie graph, hospitals are 40%. So they're by far the biggest element of the overall cost. It's scary from the perspective of hospitals buying physician practices to drive that cost up, and also because of the reference patterns to the more expensive facilities. So I just bought this reference. I can charge them anything I want. There was an intriguing article in the New York Times on Saturday, and it was dumping on the state of Georgia, primarily for not expanding Medicaid. And the writer was talking about an uninsured lady in Savannah, Georgia, that didn't have coverage, and she had throat cancer. And she had gone to Memorial Hospital, where I used to work, and they said, well, you know, there's not much we can do for you. You've got all these issues. And it talked about that she needed, the article talked about, the Times is a liberal rag. I mean, they were just beating on Georgia and on a Republican state. But anyway, they opined that she needed this, quote, picture of her neck that was $2,300 that she couldn't afford. Well, the picture of her neck's an MRI. So right there, what Memorial was saying is that their discounted rate, kind of their don't walk rate for an MRI, is $2,300. You can go to any independent imaging center in the country and get that same MRI from $400 to $500. If you happen to fly over to France, it costs $230. So how do you go from this poor lady, and everybody's all worried about this poor lady who needs this MRI so they can figure out what kind of cancer she has in her throat, but she can't afford the $2,300 MRI that Memorial is going to charge her. That's the problem. That's the problem. You can't give that MRI at Memorial. If they can't do it any cheaper than $2,300, she has to go somewhere else. So if she can go to one of these private imaging centers and get it done for $400, look what's available now. Also, we have a chance to get her better, but Memorial can't have that business. The hospital can't have that business. And until we start shoving things down to the lowest common denominator of cost, we have no chance to make any major changes in the way healthcare costs are in America. The lower we make the cost, the more people can afford it. That's economics 101. And if we want more people covered, we want these 18% of Americans who don't have insurance now to have insurance, the fastest thing to do is to drive costs down. And once we drive costs down, more people can afford it, more people will afford it.
Thank you, Mike. Well, it's pretty clear we're at the cusp of some major changes in the healthcare system, certainly driven by these reimbursement changes and the health insurance exchanges, the Affordable Care Act, and other things in addition to the quality movement. With that being said, we'll open the floor for any questions that you might have. Please go to the microphone back here. Good. We have some questions here, and we have a lot more ourselves.
Hi, I'm Elena Marino, owner of Employee Benefits Agency in Alpharetta, Georgia. I like that Dan and Mike, I believe was your name, sir, we're talking about defined contribution, which is a topic that's, very interesting to me, and I do think it'll solve a lot of problems. But two of the issues I see is for small businesses, that insurers are going to have to be willing to play together in the fully insured market in order for there to be, in fact, a small group health exchange with defined contributions. And the other problem I see, and I'd like to see what ideas you guys have, is that the government now has officially shut down any opportunity for a small employer to contribute to individual health premiums. They're being put between the rock and a hard place since they're not required to cover employees if they have less than 50. Chances are they're going to dump. Not just necessarily for the cost, which is outrageously more, by the way. I don't know where Bill got the 10%, but we're not seeing Blue Cross is from 13 to 165% in Georgia. And we've done 12-1 and 1-1 quotes for the exact same group, and it turned out to that. So basically the two issues is, will insurers play together in a small private exchange? And two is the disintermediation in the small group not being able to pre-tax individual premiums. Thank you.
Just to clarify, the 10% was the result of the Medicaid non-expansion, not other factors.
Not the total.
No, not the total.
I'll be glad to talk about the first issue of the small employers. The small employers have got a tougher hill to climb than the employers that are ERISA-based, that are large enough to be partial self-funded. Now, the market's helping there because you can now partial self-fund, be under an ERISA plan with 10 or more employees. There are not a lot of markets for the 10 to 25, but there are a few. What Dan will work on with his organization will provide some small group health plans with an ERISA-based capability. So there will be more and more opportunities for that. But it is harder for those organizations. One of the things that about the Accountable Care Act are the ACOs that will develop. As you read about the ACOs, it also promotes the fact that they want hospitals to get involved in what we should call community healthcare systems. And I ran a community healthcare system 20 years ago, so kind of what's old is new again. And again, that's more or less a hospital-based program where you have a very limited network. It's a kind of Kaiser model, if you will. If you get your services here, then here's what the cost can be. So the way small employers are going to have to work is, one, they're going to have to look for an opportunity to move into a partial self-funded format if they have more than 10 employees. And then some of the new exchanges are allowing, like employer groups, to combine together to create larger groups with independent insurance. So both of those are going to be opportunities. I don't know how prevalent they are in Georgia. There's a lot in Colorado. There's a lot in California.
So what Mike describes is, I think, absolutely correct with the small employers self-funding scenario in states which will allow it. From a public policy perspective, it's a terrible idea because what it says, if you're above the median, then go to the exchange. And if you're below the median, or below the exchange rate, and if you're not, go ahead and get self-funding. And I think you run through 3 years. I don't know. You probably have models for these things, but I don't know how many iterations, and all of a sudden you've got all the good risk over in the self-funded side and all the bad risk in the exchange, and then you're out of balance. So I think that is, and for wellness groups, that's a good thing to do right now. But boy, I don't know how long that string lasts.
Yeah, well, and I think I'm one of maybe 3 people in the world who actually believe that there is some potential for the public small business exchange. And I think it is the best vehicle to actually do what you described, which is offer employee level choice. I realize that it is not doing that for 2014. There's still the potential that it does that in 2015 and beyond. And to the extent that market rules actually allow you to do it and you don't have exactly the problem that Tom just said, where instead of improving the health insurance market, you actually segment it even more than what it was segmented before when we actually had underwriting for the small group market. I think it has the potential at least to allow for that type of choice for a small group employer.
Thank you all for your comments. If you could dare look forward 10 to 15 years from now, will over 90% of the population be covered, or what's your estimate? And the second question, part of the question is, how will the insurance sectors look? Thank you.
Science fiction, I love it.
And you're going to hold us to the answer.
Yeah.
Yeah, if it changes like the iPhones is changing.
So let me play science fiction a little bit, alternative futures, I guess. When you look at what's happening in 2014 in Georgia, if you look at the Atlanta metro area, it looks kind of like what the designers of the Affordable Care Act would like to have. We'd like some more insurers, I suspect, a little more competition, but it's there. The potential is for others to come in. The prices are as low as they're any place in the state. When you look outstate at other areas of the state, you don't see that competition. You don't see it at all. And Georgia's not unusual in that. If you look across the nation, you see the same kind of phenomenon. You have a very different insurance market, healthcare delivery market, urban versus rural. And what that says is that there's two ways this can go. The hope is that competition in the markets that are competitive will help to change the way healthcare is financed and delivered in other markets and hold down cost. And I think Mike is thinking baloney in his head right now on whether that would work or not. But that's one hope. The other is that you create a mixed model of a very steep regulative system where markets are deemed uncompetitive. That is, prices are, by regulation, defined. We use reference-based prices everywhere in the state, even though based on some competitive portion of that state. I would also argue, and I'll shut up after this, but the Affordable Care Act was inevitable. It is inevitable. That is, it's not just inevitable that healthcare reform happened, but that it happened in the way it did. The details we can argue about and reconstruct and do better, but the basic framework of creating these exchanges and redefining the insurance markets in ways that get rid of risk was the only way to make the health insurance market sustainable. So in the future, you could make a pretty cogent argument that if this fails, that we'll have something that looks like Medicare for everyone. And I don't know if that's 10 or 15 years or 20, but those are the two paths that we have to follow.
Well, let's see, 10 or 15 years, how many electoral cycles is that? You know, we've all been impressed by how many years we've bumbled along at this and how long it takes to make real change and how all of a sudden when real change occurs, everybody wonders, how did that happen? So you know, if this fails, and when I say this, I don't believe that ACA will fail the same way in every place or succeed in the same way in every place. I think that there will be some really bright, shining examples where, as Bill said, there's competition in the market. It functions as an insurance market. I think there are places where the subsidies will work. There'll be a level of education where it works. And you know, Massachusetts in some ways works, although there's some very specific things which are inherent in Massachusetts. That said, if you have the right administration and the right amount of cost and the right other kinds of things exploding in the bad way in the economy, yeah, you could see Medicare for all at a certain point. And yet America's version of Medicare for all might look a lot like Medicare Advantage for some and everybody else is something else.
Well, I think I grew up in a small town in western Michigan, which I probably shouldn't say here because it discredits me not being from Georgia. But whenever anyone who's in my family asks me what I do for a living, I give them this long-winded answers with lots of multi-syllable words, and then they say, well, that doesn't sound like it would work here, and I have to acknowledge you're right. I don't know what the answer is. I moved to DC when I was 28 because I thought I had all these great policy ideas and it would be a lot of fun to go there. And it turns out that rural healthcare is a really, really, really difficult problem to solve. A community that needs to have a hospital, what I'm quite convinced of is what we're doing today in Georgia is the fastest way to make sure there is rural healthcare in the state of Georgia. But I don't know what the answer is to rural healthcare. I think in markets, and Tom taught me a new word today, micro-competitors. I think that's exactly right. That's what's going to happen. I believe in 10 or 15 years, you're going to see a lot more entrance into big areas where there is some competition that's happening. I don't know what the answer is outside of those areas. It very well could be just what Bill said. It's a difficult problem to solve.
Well, the certificate of need laws is the biggest problem we have in the rural markets, and not being able to build new hospitals. The publicly owned hospital facilities target hospitals in very rural markets because they can charge anything they want. They're the only game in town. And until we stop that, then the rural markets are done. And as healthcare gets more mobile, as you can receive more services by traveling or by video, the AMA says 80% of all primary care visits do not need a face-to-face visit. As you can receive more healthcare mobily, then the rural markets will dry up except for sort of emergency care kind of services. And that's what needs to happen. When the hospitals in Statesboro, Georgia, which is owned by the biggest hospital bandit in the country, when they start moving to Atlanta or to Macon to get their services, then all of a sudden that hospital will have to find a way to comply, or they're going to have to deal with a lot smaller base. Once we eliminate certificate of need laws, which I assume we will in Georgia at some point in time, then you can build another hospital down there. The county can own it again, and then you can have a competitive environment. But until then, there's nothing's going to happen. They're going to have to travel somewhere else.
Pat, do you need to make some closing comments now? Or?
When you finish with all those questions.
Okay, one more question here. Yes.
Maybe this is for you, Mike, but how do you attract doctors to a Henry Ford versus a Cedars-Sinai or UCLA?
I don't know. I don't know. I mean, they're going to go where the business is. They're going to go where they can make the most money for what they do. So obviously they want to stay busy. So if you have less competition, so I guess it's all relative to the market that you're in. But I don't know how you attract doctors purely on, you can have all the business you want and price it any way you want from this point forward. I don't know that it works right now for anesthesiologists. It works probably for surgeons. But I think they're the only two sets left that really works for.
Question?
As a minor follow-up, what is the core of the reference-based pricing system? Where do you get that?
Yeah, you got to have a baseline. So typically Medicare being the biggest payer, Medicare is the first benchmark. Cost to charge ratios when Medicare is not available, because Medicare doesn't apply to, say, pediatrics. So you'd use cost to charge ratio. So every hospital in the country that accepts Medicare or Medicaid has to report their own costs, and that's what Medicare is built off of. So Medicare itself is a cost-plus system. So if you base reference-based pricing off of a cost-plus system, then you have something to work off of. There are about 250 employers in Texas, mostly in South Texas, that have completely dumped their PPOs, completely dumped all their relationships with Blue, United, Aetna, and Cigna, and moved straight to reference-based or cost-plus pricing. None of those employers have been sued, none of those employers have blown up, and they're all buying healthcare services for about 120% of Medicare, or 125% of CTC ratio.
All the big consulting houses will gladly sell you that service based on their experience in the data set that they have available. At least that's my experience.
Any other questions? Yes.
Kevin Lee from Emory University Office of Technology Transfer. I may have naive questions for you. It is about the health insurance exchanges. I guess they borrow this concept from the capital market, but would you please explain the concept of exchanges here? In other words, how exchanges are conducted. My understanding is that it's a one-way transaction. You either buy or sell. You really cannot do both as you can do in the capital market.
I don't exactly. It is not a financial market model that you're using. It's a retail market. And so you have, the exchange is supposed to be a place where consumers can identify a variety of retailers, insurers, gather information not only on price but on other metrics, quality of care and networks and some other things, and make informed choices. And the theory behind it is that by creating that kind of a market where insurers have to take everybody, so they cannot compete on risk, that they will compete on cost and quality. the theory behind the Affordable Care Act, and therefore consumers making choice will drive insurers to find ways to recontract with providers in a way that creates a working market and controls costs. That's the theory behind the health insurance exchange.
Actually, for one thing which I read, the reason they wanted late to move to the health insurance marketplace is because when they tested health insurance exchange, people like yourself said, well, what am I exchanging something for? And all of a sudden became very uncomfortable with the word exchange, so marketplace was adopted halfway, quarter way.
And that was a word that the Republicans in Congress spent
Right.
a couple
The
years
term
bashing.
health insurance market.
It had
Very
very little brand.
Any final questions? Okay, on behalf of the panel, we'd like to say thank you to you as the audience, and thank each one of our panelists here.
My closing remarks stand between me and over there where there's wine and cheese at a party that all of you were invited to. So they're going to be very, very brief. I'm Pat Williams. I'm chair of TAG Health. I had the privilege of being one of the founders and creators of the summit 4 years ago. So we have a toddler now. We're 4 years old. We're delighted at the progress that we've made and the growth that we've made. Thanks to all of you for being here. From the perspective of TAG Health, if you would stay tuned or look online, we have some great events lined up for this year, beginning in January at the Capitol. I don't think that flyer was on the TAG table today, but it's at the Capitol. If you look at tagonline.org, you can find that. It's promising to be a great event. We're partnering with Georgia Hymns on that. And then beginning every other month, we have one in career fair in March, early March. So that if we'd love to invite all of you to be part of that if you would. And on through May and June, we have June and July, people were requesting other events and additional events. And then into September, we have innovation and disruptive technologies and all sorts of good things. And then back to the summit again. So we appreciate you being here. We appreciate those of you who have been sponsors. There's a lot going on in health IT, and we're really looking forward to growing the health IT segment in Georgia and beyond, sustaining the 250 companies that we've had, and building a workforce and making sure that our companies have what they need to stay and be here. I tell everybody that my measure of success is that when we have a coffee shop in Seattle and you have two people sitting there talking, and one says, you know, I'd really like to get into health IT, and the other one says, well, if you're going to do that, you have to go to Atlanta, Georgia. So when we get there, and I can imagine that we will be there. So thank you all for coming, and all of you are invited to the party next, right around the corner, and the reception, and we'll see you hopefully at other events during the year. Thank you.